Hi, everyone. This is Melinda from the European Pain Federation, EFIC. We are here for our EFIC Academy webinar on the topic of pain physiotherapy, and we have speakers joining us from two newly released sessions on our education platform. One session called Acute Pain in Sports, and the other one called Exercise and Chronic Pain. So we're just gonna give you a minute or so to settle in, and we'll shortly start with introductions. So just bear with us. And as a reminder, these sessions are available on our education platform. So we have asked you to watch those presentations beforehand. And this is a Q&A webinar. So this is your chance, your opportunity to ask questions of our speakers, really, interact and engage with them. And you can do so via either the chat function or the questions and answer module that you see at the bottom of your screen. This webinar is also being recorded, so of course you can watch it later on as well. All right, so I think we're just going to start, kick off with some introductions. And why don't we start with Ben? Ben Smith, please. Would you please introduce yourself and tell us a bit about your presentation?
Sure. Thanks, Melinda. Hi, everyone. I'm Ben Smith. So for those who don't know me, I'm a physio clinical academic based in Derby in the UK. I work at University Hospitals of Derby and Burton with the University of Nottingham. So one of my special interests is people with patellofemoral pain, so pain around the kneecap. And a few years ago, I ran a program of work where I developed a complex intervention, a psychologically informed complex intervention for people with patellofemoral pain. And one of the elements of that was the concept of pain and exercise, and whether there should be pain with exercise or not, and whether it's any use or not. And so my talk was around that small element, pain and exercise. And the summary really is that generally it's become a bit of an elephant in the room, pain and exercise, in that it's generally not particularly reported in the literature. Certainly guidelines for researchers when they write their research doesn't mention pain. Clinicians are largely fearful of it, with a large variability in practice. Patients often demonstrate pain-related fear and cultural beliefs around pain and exercise. And it's a very important question for patients, pain and exercise. And my perspective is that maybe pain with exercise might be useful, might be good in terms of optimizing dosage and correctly titrating the dosage of exercise, and may help with pain-related fear. But certainly pain need not be a barrier to exercise. And just one final summary really is that I think there's a lot of uncertainty with regards to exercise and treatment for people with pain. But what we do know is that there's a strong link between physical activity or physical inactivity and ill health. So people with musculoskeletal pain, about 75% of them will drastically reduce or stop participation in sport and physical activity. Physical inactivity accounts for about 1 in 6 deaths in Europe. And people with musculoskeletal pain have a 17% increased risk of chronic disease like cancer, diabetes, and heart disease. So I think when we treat our patients, we need to try and link or bridge the gap between individual health and public health. Thank you.
Thank you so much. Morten, why don't you introduce yourself and tell us a bit more about your talk next?
Thank you, Melinda, and I will. My name is Morten Høy. I am a physio by background. I'm also an associate professor at Aalborg University, and I think I would fit into the category of clinical scientist or clinician scientist as well. I have a strong interest in the basic research in pain and pain mechanisms, particularly within the musculoskeletal field. And the talk that I was sharing with Tim and Tash was on acute pain, and particularly in relation to sports. One of the things that is coming out of our understanding of pain as it is now is that pain, of course, is much more than nociception, and nociception is part of any injury. So what's the difference between being injured and feeling injured or vulnerable, as an athlete would say it? And that's what I discussed. So the difference between feeling injured or being in pain, as opposed to having an injury to the tissues and how do they correlate and what's the difference between them. And we came out with this infographic about a year ago, a little under a year ago, in the British Journal of Sports Medicine, where we tried to come up with these new semantic entities so we can better discuss what are we talking about. Is it sports-related pain, as in the pain itself, that's the problem? Or is it sports-related injury, which might also hurt, but imagine you're like an ACL tear, so a cruciate ligament in a knee tear. The element of pain is going to be there during the inflammatory phase, but it will slowly decrease afterwards, whereas the instability and the dysfunction of the biomechanics of the knee will remain on, until it's fixed or compensated for by the muscles. So this idea about injuries not equaling pain, we've tried to expand to sports medicine.
Wonderful, thank you so much. Tash, can I ask you to go next?
Yeah, of course. I was excited to be part of this. This is always a lot of fun when we get to do Q&A. But for those of you who may not know me, I work as an associate professor of clinical pain neuroscience at University of South Australia. And I also have background training as a physiotherapist, although probably a bit counter to Morten, I would say that I'm probably more heavily researched than clinical at the moment. My research interests pretty much span all things persisting chronic pain. I'm quite interested in understanding a bit more, what sort of systems, sensory modulation systems might still be intact in these conditions, and can we use them to our advantage through things like virtual and mediated reality? And as well, I've done some work with sports-related pain in terms of collaborating with some different athletic teams, some from Ireland, some from Australia, and that's really piqued my interest in that area of sports. So my presentation really probably, I'd say, built on Morten's talk and explored this idea that pain and injury aren't necessarily synonymous. So for example, you get athletes who are uninjured and asymptomatic, but they have changes on scans. And so to me, this highlights this idea that we need to be prudent in our interpretation of scans. But a finding like this also really underpins the importance of embracing the modern understanding of pain. So this idea that pain is complex and it has many different contributors, and therefore clinically, there's a real relevance in exploring those unique contributing factors for each individual athlete, and whether or not, these factors can contribute to either the available evidence of danger or the available evidence of safety, of which we argue the balance determines how much we hurt. And as clinicians, those contributing factors, that can include our words, how we speak to the athlete, but also all the things that are going around in that athlete, their environment, their mindset, their support, but also critically their own understanding of pain. Because ultimately they're training at this, hugely high level. They're pushing the barriers at all times. And this means that they're potentially pushing or going into what we term their safety buffer. So when they push into safety buffer, they often feel pain. So it kind of gives us this framework where they can experience actually an increase in pain, but not have been injured. And if they understand that that sensory buffer is dynamic, it can change based on what's going on for them in their life. It can also help them understand why actually they get seemingly random pain fluctuations. Doesn't necessarily mean injury, but might just mean increased protection of the system. So, and I think underpinning all of this is this, real important understanding of the fact that we're bioplastic, that we're changeable, that everything is adaptable, is actually a critical message for athletes to, deeply understand that things don't just get worse. They can also, change for the better, and we can be part of that journey.
Wonderful. Thank you so much, Tash. And now, Tim, would you also introduce yourself and tell us a bit more about your talk? Thank you so much.
Hi, I'm Tim Watson. It's nice to come back and join you again. Tim Watson, I'm based at the University of Hertfordshire. I'm about to retire for the second time in a few days' time, but I don't think that's actually going to happen either. Anyway, University of Hertfordshire in the UK, and I'm a visiting professor at Lincoln and a few other places. I'm the interloper on this panel because my talk wasn't primarily about pain. My concentration was on the tissue repair sequence, which has been one of my passions for the last 40 years, on the basis that if we try with therapy to influence the state of damaged tissue, it makes a whole lot of sense to understand what the doobies actually happens when tissue gets damaged and how it repairs. So my focus was on that sequence of repair. It had relevance to pain, and I dropped some pain elements in there, but the primary thing was, does tissue mend? Yes. Can we influence it? Yes. We're not trying, my critical message is we're not trying to change how a tissue repairs with any therapy. And in my humble opinion, any therapist who tries to change how tissue repairs is daft, because the repair system is pretty damn clever. We should be playing it for all it's worth. Stimulate it, promote it, advocate it, enhance it, enable it, whatever trendy term you want to use, but don't try and change it. And a lot of our patients have a delayed, a dysfunctional repair system, and therefore our task is to stimulate the normal sequence, not to stimulate some new invented sequence which only therapists have access to. It's crazy. So whether the tissue is healing normally or whether it's delayed, our task is to stimulate the repair sequence. And the evidence out there says that we're perfectly capable of doing that, which is a positive. And therefore, that links in with the other guys' talks, and it will influence pain. But as I say, I admit I'm the interloper because my focus is on repair, not on pain. Anyway, we'll take it from there.
Definitely not an interloper, and very, very happy and thankful to have you, Tim. Thank you so much. We're all about, approaching this from different aspects and looking at it from all different sides. So I think we can all agree there. Now, just a reminder, you can always ask any questions at all, but to start us off, we of course have a few of them prepared, and I would like to start with Ben Smith. So Ben, you argue that it is time to think differently about exercise and chronic pain, and that clinicians shouldn't be telling patients to avoid exercises when painful. So how do we go about communicating this to patients if they are in fear or if they have strong beliefs about around injury?
Yeah, that's the crux of it, really, isn't it? How do we, what are the words, what are the key words and phrases, or sometimes I think about the variables we use to try and help teach the patient how to manage their activity levels in pain. I think the first fundamental aspect is that we need to understand where they're coming from, what their current beliefs are and attitudes to exercise, activity and pain, and how that currently affects their behavior. And then we can calibrate our advice and our exercises around that. Because if you give someone an exercise that aggravates their symptoms, if they have an underlying belief that pain is tissue damage and that it will make their symptoms worse, then it's no surprise that it will flare them up and they won't get any therapeutic benefit from the exercises. But that said, I think actually with a bit of pain with exercise, we can actually use it as a tool to educate the patient. I think people like the phrase expectation violation or graded exposure or experiential learning or whatever phrase we like to use, but we use it. I think it's good as a tool to sort of to teach the patient that it's okay and they can cope with it, and they don't get the flare-ups. But I think fundamentally it comes to when you're talking to a patient about exercise, and I like the patient taking charge of their own exercise and them dosing their own exercise. So rather than me telling them what to do, I teach them how to self-titrate or self-dose their exercise. So so one of the variables I talk about is pain with exercise. How much pain is okay, and there's a lot of debate about whether a pain scale should be used or not, and what pain, what number out of 10. I'm a big fan of words, so as long as the pain is tolerable or acceptable to the patient or the participant at the time they're doing it, then I think that's a green light to carry on. And then obviously there'll be a flare up afterwards. So how long will it be sore for, or increase sore pain afterwards? Again, there's different time frames. I think I did a systematic review where the longest was 24-hour flare up, and that still had favorable outcomes. So you could say, well, the evidence says up to 24 hours, but again, I tend to like to use the words acceptable, which then then allows you to use a bit of common sense. It kind of depends what they've done. If they've run a marathon and they're sore for a couple of days afterwards, maybe that's okay. If they've walked for 10 meters and they flare themselves up for 24 hours, I don't know, maybe that's a bit too much. So as long as the flare up afterwards is acceptable for the pain level that they're in and the amount of activity that they've done. And then I guess the last variable really is over time, what's generally happening. Is their activity levels increasing and they're able to stabilize their pain levels, then that's good. Or is their pain maybe even decreasing? But certainly as long as we're not getting a gradual increase in pain over a number of days. So that's generally the word, the topics I would cover, probably over like an hour session with a patient, but that's probably how I would go about it.
Wonderful. I see Morten. Sorry, I see also Morten has a comment, but Tim, go first. Go ahead.
No, that's fine. Go on. Morten's done the right thing and put his hand up. I'll put my hand up. Go on, Morten, you go first.
Thank you, Tim. Ben, would it be fair to say that what you're saying, if you wanted to dichotomize it, would be between controllable pain and non-controllable pain? So it sounds like pain is not dangerous as long as you can control it, and you say feel comfortable with it, but I assume that's being in control of it as opposed to not being in control of it. Or what are your thoughts on that?
Absolutely. I mean, I don't know what the best words or phrases to use. Controllable. I've not personally tried that with patients, or in the research I've done, but I immediately like it, and I think it's a good terminology of that. We could maybe link it to self-efficacy and locus of control. Yeah, I like that. Yeah, it's good.
Yes, go ahead, Tim.
Right. Okay. So when I was working back in professional sport some years ago, some decades ago now, for God's sake, I used to have almost the opposite problem, where instead of trying to encourage the patient, athlete, or whoever to work and not be scared of pain, they were almost coming at it from the other end, and the classic no pain, no gain syndrome, where if it doesn't hurt, it must be a waste of time. So can you just flip your argument the other way round? How do you tackle that?
Yeah, I mean, Tim, that's a great question, and for me, I think that's the beauty of using pain to dose the exercise, and that's a common negative comment or critique of my work, in that people would sort of flippantly say, oh, well, you think I should go and do this and have this amount of pain, or you think, oh, you just tell everyone to go and
I'm sorry, did he froze for everyone or just for me? Okay.
Yeah, no.
We'll give Ben a couple of seconds to recover his connection. But thank you so much, Tim, as well, for asking him to flip it around. It's definitely an interesting one.
I think maybe if I can elaborate a bit while Ben is getting his internet together. Maybe also what I think Ben is talking about is the fact that when we want to get people back to sports, for instance, if they can't do it without pain, that would be fine. But ideally, pain or sports shouldn't hurt you. So if you're playing soccer, that ideally shouldn't hurt you, because it might interfere with your ability to perform. But I think what he's saying is that even if it did and you were comfortable with it, it's not dangerous. Is that what you were talking about, Tim?
Yeah. I mean, I've never liked the idea of no pain, no gain. It doesn't, as a therapist, as a practitioner, it doesn't appeal to me. And I used to almost advocate against it. But I was just asking if Ben had whether he had a way of playing his words on the flip side to try and get people to not be stupid. I mean, if it hurts, it hurts. And I take Ben's point, but it doesn't have to hurt. You don't have to push an exercise or a stretch or a maneuver. You don't have to push it to the point of pain before you get benefit. And a lot certainly in the professional sports world, seem to hang on to the belief that if it doesn't hurt, it's a waste of time. And I don't like that. I just wondered how Ben got around it.
Yeah, Tim, to speak to what you're saying, I really like that idea of the other way around, because I think when we look at some of the, I guess, looking into chronic pain type research, many times when we get people who have quite high levels of irritability, so small things will actually cause a large flare. We almost see this similar situation as the no pain, no gain, where you almost need to do things that sneak under the radar, so to speak, of that really reactive system. And I guess I just wonder sometimes when we have people that might always be pushing so hard, so it always has to hurt, otherwise there's no benefit in their minds. In fact, are we training systems to begin to detect things earlier because they know you're going to be silly and push too hard? Like, I think it's a really interesting dynamic of what happens over time when we repeat things numerous times and maybe don't listen to what's going on in our body. So it's that unique balance, I reckon, between what can be potentially possible and good to push the boundaries a little bit, but not push so hard that basically you're causing that flare and potentially even like you are injuring yourself in some of these athletes. So yeah, it's a really interesting area.
While we're waiting, I'm just saying that Ben has a message that he had a power cut and he's trying to rejoin us, but please go on in the meantime.
Yeah, I was just thinking about continuing this sort of dialogue on pain in sports, and the problem, of course, is when pain is not an option anymore. And Ben was alluding to this in his introduction as well. So for anyone, being mobile is much better than being immobile. We all need that movement as part of our daily life and daily routines. And not having the opportunity of pain relief is, of course, going to be a barrier and demotivating. Any thoughts on that from any of your sides on how to, despite pain, help people being active?
I guess from one sense, we can maybe use some of the available data that we have that show that this isn't in a sports context as much, but this is probably in a chronic pain context, that oftentimes what we see is that when people start to move, if we start to do this appropriately in a graded manner, we actually don't see changes in pain until about 6 months. But it seems to be potentially once you get activity levels up to a sufficient amount that perhaps your daily activities or the things in your life, they're not pushing past your capacity, then actually it seems to be at that point that you get a pain reduction. So potentially it's also framing expectations that, and this could be relevant in an injury situation of, here's what's going on in your system. You have all these beautiful inflammatory mediators that have been released. You are more sensitive. So it is going to hurt a little bit when you're doing this, but here's what we're going to do to try to keep it in capacity. This is the projection of when we do think that actually your pain might start to go down. But at first, what you should expect is increasing levels of activity, but your pain staying relatively the same, and almost framing potentially expectations in that manner. Yeah,
I agree. That's pretty much what we were talking about at the EFIC TV, which will be available on the Academy soon, with doctors or professors Henrik Vector and Kathleen Sluka. Namely the fact that being immobile is likely to be leading your nervous system to be more sensitive, to be honest, and then starting to do exercise on a sensitized nervous system is likely to cause you pain. But if you keep that routine up, you maintain it and being regularly active over a period of maybe months, the pain that you experience during exercise should go down. At least that's what we see in animal studies and people with chronic pain. And I would assume the same is true for sports. At least I've seen that quite a few times where athletes, they come back to sports, they would have been out perhaps with injuries, so to speak, such as what we consider to be overuse injuries, like Achilles tendinopathies or deep tissue thingies, groin-related pain perhaps. And whilst there isn't any sign of injury, they still have pain. And what's commonly been done is that we try to keep them under the radar, so we keep them moving without making pain worse, But what it turns out is that actually some of these can go out and be much more active with a degree of controllable pain, and helping them do that and supporting them, and of course providing the context that makes it possible for them to do that and feel safe when doing it, really seems to be a path that we haven't looked so much at in sports medicine.
Yeah, I mean, if I can jump in very briefly, I think part of what therapy does is it plays with that threshold, and it comes back to Tash, your point about that balance between acceptable risk versus safety, or danger safety. I think part of what we do in therapy, overtly or not, is we play with that threshold, we play with that balance, and therefore we help the patient, the recipient, to understand something about that balance. And by helping them to understand it, it comes back to your point, Morten, about, they can then do more activity, but for the same amount of pain. Now, that doesn't mean to say we're trying to take the pain away. The patient thinks our job is to take the pain away. Actually, if we can help them to understand that relationship between safety and danger, and that they can do more activity without increasing pain, then the patient's a winner. And some of us do that overtly, and some of us do it covertly, but I think or even unintentionally, but I think it's part of what we do.
And I can see we have Ben back. Thank you so much for working to rejoin us. So sorry you had a power cut at this exact moment.
Yeah, sorry, and then it takes 20 minutes for the computer to reboot.
No problem at all. We actually had a very interesting discussion going forward, but I have actually a question on what we were just discussing with regards to athletes and how they can understand pain. So do you think that an athlete needs to understand pain neuroscience in order to improve? Like, is the actual understanding important of the athlete, or is it more important that a clinician provides reassurance, helps with scan findings and avoids unnecessary labels? What is your view on that? That's a question to everyone, so whoever wishes to answer.
I might start on that one if it's all right. I think I would argue that probably the available evidence that we have would suggest that there'd be more available evidence for things like reassurance, and in some cases of validation of the symptoms that people are experiencing and the fears and the anxieties that go along with it. And I guess having a background in pain science education, I would probably argue that no one necessarily, like, it's not a blanket thing that every single person needs to have X intervention of this. But I guess what is relevant, and I think what Morten and Ben have both sort of referred to, is this idea of for this patient that's in front of me, what are the barriers for that person in doing their valued activity, whether that's sport, whether that's general physical activity? And then if this barrier exists, is it possible, like what beliefs do they have around that? What are the underpinnings of potentially that fear, that anxiety, that worry? And is it possible that if we went into a discussion of some of the increases in knowledge that we have had about pain, would that be relevant to help shape or remove that barrier? And I guess we have gone into the educational field and looked into different strategies, and sometimes when there are strong beliefs that are potentially holding people back and acting as a barrier, sometimes just giving new information isn't enough. It requires a method such as holistic confrontation, where it's saying, this is your belief, this is what the available evidence suggests, the most recent evidence. So it's sort of actively coming into a conversation about that. And that, of course, is dependent on that, rapport and that relationship that the clinician has with patient, whether it's athlete or chronic pain. But I think that probably as a blanket statement, I say no, but I think as a nuanced approach to an individual problem, I would say, yes, it would be something I would consider.
I can follow up on that. I think that's a nice and balanced answer, and I would agree with that. Just to sort of maybe differentiate a bit, I think neuroscience as the science is not necessarily something patients would have an interest in, just like I don't have an interest in accounting. So sometimes you just want an answer. Whereas I think neuroscience is important for clinicians and researchers alike, because it's sort of the way we study pain nowadays. But I think using metaphors based on the science that conveys a sort of modern understanding of what pain might be, and explicitly how can we explain pain that is not explained by an X-ray or an MRI. Actually, I think there we have some explanations in the neuroscience that could be conveyed in patient language, although I probably would argue that we should try to use less of that jargony metaphorical explanations where we tell people that central sensitization is doing this, or their pain is nosoplastic, or that sort, because whilst they might be valuable concepts in the science, I think patients would perhaps better understand it without the jargon. That is, that pain can be, excruciating even if nothing is wrong, and we believe that maybe the nervous system can be exaggerating or overdoing the impulses or the signaling. So I definitely think metaphors could be good, but separating it from jargon and understanding the science would be sort of maybe more precise way to go about it.
So with regards to understanding the science, there's a huge culture of early imaging, of rest and manual therapy among athletic populations. And this can, of course, also be encouraged by the management of athletes, not only the clinician and the patient. Is that something that should be changed? How can it be changed? And, to say that there's an alternative based on pain science is better, and understanding the pain science behind that is better. What would you say? Morten, it's a question for you.
Okay, thanks. Well, I definitely have an opinion. I would say that so that there are some good science suggesting that sports medicine is one of the last strongholds of the biomechanical approach to understanding pain. That is, there's a strong relationship in much reasoning in sports medicine that there's a relationship between damage and pain. So if a person is in pain, you would look for the damage, and then you would treat the damage in order to get rid of the pain, which is exactly why we try to do the infographic I mentioned earlier. And that is a fallacy. That's not how pain works. So definitely, I mean, if your assumption, or if you want to send someone off to imaging because you don't understand pain, then that's exactly what's going wrong. You don't understand the pain. What you should be doing is, of course, understand the pain, because you don't need imaging to do that. On the other hand, if we have good reason to acquire imaging, such as not being able to falsify the theory of serious pathology, for instance, well, in that case, it might be a good thing to. Well, it is a good thing to use imaging, but they should be used just like we would use them for recommendations for low back pain. It's not different in sports medicine. So I wouldn't encourage early scans just because you don't know what's wrong. I think it would be more fruitful for everyone to understand what pain is all about, and that it doesn't equal damage.
Yeah, I agree, Morten. And I think I guess to build on what you're saying, I think there's certain relevance, of course, when there is a mechanism of injury that would make sense to why we would be doing a scan, and particularly when the findings that you would have on that scan might have relevance for the clinical course of treatment. I think where it becomes challenging is there seems to be a lack of discussion of the iatrogenic harm that you potentially get from scan findings. Because, I mean, in many cases, what we see is that scan findings, they were probably there before the injury in some cases. If we're looking at things so-called degenerative, which I feel very bad about saying that word, as I advocate to not use it. But then you get this potential where there is a labeling or a diagnostic kind of crutch that is potentially occurring that can be really, really powerful for athletes as well as non-athletes alike. And I think, a real nuanced look at what happens actually when we give people's information like this is actually quite important, because I think that there's a thought that if we look at this and get down to the cause, performance will improve. But what if we have the exact opposite result, that showing some of people some of these scary pictures actually is doing the exact opposite of what we might think?
And I think, just to sort of add a bit of extra on there, that the potential for scan, the value of, or potential value of scans, put it like that, is great from a clinical perspective. And patients tend to take our casual scan comments in a completely different way. And like you say, Tash, about the degenerative comment, we might throw in there, oh, there's a bit of degeneration in your lumbar spine. What they take away is that the therapist says, the physio says, the doctor says, my spine's worn out, and therefore their mindset now changes. And it was a throwaway comment. It wasn't a serious, this is the root cause of your pain. It was a throwaway comment, which they've latched onto because they understand it. And therefore both therapists and patient, or practitioners and patients, can take away the wrong message. And yes, I love, scans were never available when I was certainly in professional sport. You had to be at the end of the line to get a scan, way down the line. Whereas now, you come off the pitch, they almost have got, pitch side scanning almost. And therefore, both the patient and the therapist and the practitioner have a tendency to be over-reliant on the scan. And therefore, you add these quick and easy labels, you add the throwaway comments, and it gets taken the wrong way. So they've got great value, stunningly great value, if they're used appropriately. But we all need to be aware that the throwaway comment is not just a throwaway scan comment. It's a throwaway comment when you're doing your assessment. Your throwaway comment when you're doing your sort of your educational chatty thing. The one-liner that we don't attach any value to might just be the one thing that they latch onto and will not let go. And we don't always do ourselves the best favour in the world.
So, Tim, can we, to pivot a little bit to your presentation and your topic, which is about healing and inflammation. In your presentation, you say that ultrasound and other electrotherapy modalities can promote repair, but are often discouraged for chronic pain because they are seen as passive treatment. Yep. Can you elaborate a bit on that, or what is your view on that?
Well, I think there's a difference between fashion and evidence-based practice, and we all know that. And certainly at the moment, the electrophysical modalities, whether that's ultrasound or laser or shockwave or whatever, are not in fashion. And therefore, the label, things like, we don't do that, we discourage it because it's a passive intervention. I absolutely understand the concept of a passive intervention, but that doesn't mean it's wrong. So if you've got a damaged ligament and your ligament needs to run through a repair sequence in order for integrity to be restored, if I can do something that helps you and your damaged ligament run through that process, why is that a negative? I think an over-reliance in the past has not helped. People came in and everybody got ultrasound or shockwave, or not shockwave, it didn't exist, did it? Ultrasound or laser or interferential or TENS or some other modality. And it was massively overused. And that was on the back of no evidence. We've now got evidence. We now know which modalities do what. And therefore we can be selective based on the evidence. I wouldn't use any modality as being better than exercise education, stretching, PNF, manual therapy. I don't think that any of the electrophysical modalities are better than any other modality. But if I've got a modality available which helps you and your damaged tissue go through the required repair process, why wouldn't I use it? If you were the patient and you had the ligament tear and I had an ultrasound machine, I'm saying, oh, I know I've got an ultrasound machine, but I'm not going to use it because it's out of fashion. But the ultrasound machine is going to help me mend in less time. If I'm the patient and it's my ligament tear, I'd rather like you to use it, please. And you may not like it. You may think it's passive. But if that takes 30% off my recovery time, I'd really like you to plug it in, please, and use it. So that's the difference. The difference is, in the past, we've over-relied on modalities. In the past, we claimed they do things just by themselves, which is true. I think the current use of modalities is as a way of supporting, enhancing, helping the sequence of repair, and therefore in that context they have potential value. And if it was you and you had a fracture and your fracture was going to take X amount of time to mend, and I used a modality and I reduced your repair time by 40% of your fracture, why would that be a bad thing to do? If I can reduce the time it takes your fracture to mend without loss of quality, I'm not making it fast and rubbish, I'm making it fast without loss of quality, that's a potentially valuable intervention. It doesn't cure the problem, it doesn't solve the problem, but it's better than not doing it. So in my view, they have a value which is evidence-based, and our evidence says we can be selective about which modalities to use and when. Some of the applications, I look at the historical stuff because I'm old and I'm a dinosaur, but I look at some of the historical applications and they were absolutely pants. They were so pants as to be pants beyond pants, and they were awful. Not because they were dangerous, but because they never could have done what it said on the box. We now know better. So it doesn't mean they're rubbish. It just means there's a way of thinking about them which is positive rather than negative.
Thank you so much for elaborating on that, Tim. I see Morten has some input here.
I'm going to take the opportunity to ask you in person, Tim, just a reflection first. I was chatting to Kathleen Sluka about this as well. So she uses TENS for people with fibromyalgia, and her studies, it shows that they get more active. So it creates sort of a window of opportunity, if you like, where they can be more active with less pain. So applying TENS actually helps them become more active, which then itself would have sort of that change in pain we discussed earlier. But I guess just reflecting on why isn't it in fashion, I think when I was learning about electrotherapy, all of the modalities, we learned all the stuff that you just mentioned, but I think what took it out of fashion, for me at least, was not so much that it was passive, it was more that I couldn't make it work. So I think I share that experience with many clinicians of my generation. Why do you think we couldn't make it work? Is that because we were hoping for miracles? Or what do you think was going on?
Excuse me. Yeah, part of it I think was an expectation that this modality was going to make everything better just by applying it for 20 minutes twice a week, which is, it can't be true. But I also think, and I love Kathleen Sluga's work. I mean, she's done some stunningly good work, and that one about TENS and fibromyalgia and activity is a great example. But if our clinical decision making is at a higher level, the modalities, whether that's laser, ultrasound, shockwave, or microcurrent, whatever, the modality choice on the back of cleverer, if you can say such a thing, decision making, is what we missed out on. My clinical decision making, I mean, I trained in the 70s, for God's sake, the 1970s, not the 1870s, but that was quite some time ago. And if I relied on the clinical decision making I got taught in the 1970s, I'd still be doing abdominal massage for constipation, which was terribly good fun, but probably not a mainstay of my practice. So our clinical decision making needs to be at the more advanced level. The modalities are the modalities. How we pick them out of the toolbox and when we use them and when we leave them behind is the bit I think that learners of this stuff miss out on. And it takes effort. But it takes, Ben, it takes effort to choose the right exercise. It takes effort to educate the patient, to get them to choose the exercise repetition level. It takes effort to choose a manual therapy which is appropriate and knowing when to leave manual therapy out. So in therapy, our clinical decision making is more advanced now than it was 45, 50 years ago. And that, I think, is absolutely key. And it's not that the modalities are better or worse than they used to be. It's how we process it as a therapist, as a thinking therapist, not as a recipe therapist, I think.
Yes, go ahead, Tash and Ben, whoever wants to go first, sorry. Ben, okay. You go first, Ben.
Thanks. Yeah, I've got a question for Tim, if that's all right. Thanks, Tim. It's really great to hear your perspective. I just had a question about when you're talking about using electrotherapists to reduce healing time. I'm assuming you're talking about still the sport population. What's your view on that, say, in terms of the context of a public health system where there's a 6-month waiting list to see a therapist?
Yeah, I mean, I think in the public health, certainly in the UK, the public health system is not well equipped to play in this game. So if you are a patient and you are 65 years old and you've got a fractured tibia, there is no doubt that I could use ultrasound and reduce your fracture healing time from your tibial fracture. The public health perspective is 95% of fractured tibs are going to mend anyway at some point. And therefore, let's not spend money on everybody because we can't afford it. So let's only spend money on the 5% in whom it goes wrong. Now, in professional sport, you being off the pitch, you being off the running track for 6 months, seriously matters. It's your job, it's your profession, it's your well-being, your everything. And therefore, they tend to get the attention. I don't think professional athletes deserve that attention any more than Doris, who's 65 and got a fractured tib. But Doris, who's 65 with a fractured tib, is not going to get it because it costs money. It costs resource. And therefore, that's a financial, political, clinical decision, which nobody will ever admit to, but that's what it is. It's to do with the fact that we can't afford to do ultrasound to Doris's fractured tib, because if we did it for Doris, we'd have to do it for all of them. We ain't got that money.
Thank you so
Tim,
much,
if I
Tim.
could-
Tash, sorry, go ahead.
Yeah, no worries. Thanks. So Tim, yeah, this is so interesting to have a good discussion on this because I don't know this literature too well. So I'd really appreciate your thoughts on this. But
you realise there's only 4 of us on this conversation because nobody else is getting a look in. It's only the 4 of us having a chat. Go on, keep going.
Yeah, that's true. I'll do this one quick then so we can get to the Q&A.
No, I don't mind. I'll think about this all day.
So with the I suppose with the idea, it seems like that there's a couple of issues or things that we're talking about here where if I've caught this right, it's that there's evidence to suggest that things like ultrasound will help with tissue healing, but won't necessarily change the pain experience. Is that right?
Well, not primarily. Ultrasound does not change your pain experience as a primary effect. But if ultrasound helps your tissue to repair, and there is a link, not 100%, there is a link between damage and pain, therefore pain relief will be a secondary consequence. Modalities like TENS are simply an intervention that changes your perception of your pain. So that's a different kind of thing. But modalities like ultrasound, like laser, like shockwave, like microcurrent, are aiming at influencing the repair sequence, and therefore there's a reasonable expectation that as a secondary effect, pain will reduce. Yeah. But it's not linear. There's no way it's linear.
Yeah, and I think it's sometimes, certainly when I was being taught some of this stuff, it was very much that if we use ultrasound, this will, yes, we will help with tissue healing, but the main thing, the output, the primary endpoint was pain. And I think that's probably clinically where some of it fell down. But I would be quite interested to see, whether you can take advantage of those healing windows potentially with, timing that. Interesting.
But I think that comes back to the point I was making in response to the question from Morton, that our clinical decision making is different, should be different now to how it was 10, 15, 20 years ago, in that it used to be talked about that ultrasound was a way of reducing pain. Well, with all due respect, that's a load of old tosh. It cannot do that job. It is not a pain relief modality. Its biophysiology responses in the tissues do not involve pain relief. So therefore, if you use it as a pain relief modality and it fails to achieve pain relief, which it will, then as a primary outcome, then people say, oh, ultrasound's a waste of time. If you use it as a way of helping the tissue repair to happen, stimulate the normal sequence, then your clinical decision is a different decision, and therefore you look for a different outcome. There's no point stimulating repair and looking at pain as an outcome. So that's what I was saying about the way we think these things through should be different now.
I guess maybe this could be a sort of bridge to maybe a few of the questions in the Q&A. So if I get you right, Tim, you would say that electrotherapy would be put, along with sleep and restitution generally, so it helps your body to recover, basically. That would be interesting. You could say sleep is passive as well, and we would definitely recommend that, wouldn't we? So yeah, so that's a whole new discussion. But there are a few questions. I don't know, Melinda, do you have any preference, or should we just take them?
I have one from Keith, who wanted to find out, so what do we know about tipping points when previously asymptomatic underlying conditions, such as osteoarthritis, they become symptomatic and painful, and therefore turn people into patients?
I think it's a brilliant question. I'm referring to Dr. Christian Peterson from our university when I say this, that having spent at least 10-15 years studying QST and what predicts good or bad outcomes after knee osteoarthritis or total knee replacement in people with knee osteoarthritis, in his words, we know about 1/3. So basically that's not really a whole lot. I mean, we do know a lot, and science is a structured and systematic approach, so we will know more as time goes, but we're still not at a tipping point where we can say that under these circumstances, it's better to have surgery than not to have surgery. So I guess, the take-home message is here, I don't know at least of any tipping point factors. What we tend to do is use this blanket of what we call risk factors, which are, sometimes just correlated factors and not even risk factors. But I don't know what the rest of the panel says.
I think it's interesting in terms of often when we look at an individual patient and when they explore, or we explore with them potentially the narrative behind their experiences, is that oftentimes, of course, that's a retrospective fit to model look where we're saying, what are the individual contributors that are going on in your life that potentially can be increasing the need to protect within you as an individual? And I think in terms of a clinical tipping point, you might, I suppose, approach that issue in that manner and kind of say, well, look at all of these things that came together, and in the absence of anything else that's changed, here we can maybe see what we might call emergence in pain. But I think, as Morten referred to, I don't think it's something that or it certainly isn't something that we have a model that we can predict it well. I think otherwise probably we would be much better at potentially preventing, which we aren't. But I think it's a brilliant discussion and a great question to have, because I think it puts into focus that if we view pain as a complex emergent phenomenon, then theoretically we have to have, I guess, potentially equally complex models or ways that we look at it to predict when it might occur.
I think if I can jump in, I think absolutely right that if we look at what we know now, let's take osteoarthritis, for example. Our understanding of the pathophysiology of osteoarthritis is streets ahead of what we knew 40 years ago, but that does not have a one-to-one transfer into clinical decision making, because knowing that there are now 150 different biochemical mediators which have an influence on it doesn't solve the problem about, we'll leave Doris alone now, we'll go to Fred. Fred, who's got OA knee and he's 69. Does Fred need an exercise program? Does he need education? Does he need surgery? And that's individual. So the information we got is massively enhanced compared with 20, 30, 40 years ago. But that has not transferred to decision making. And I come back to the same point. It's how we as clinicians use that information for that patient. And I think the individualization of medicine, I hate that phrase, but that's what it is. It's how do we turn a blinking great body of evidence into an individual clinical decision made in conjunction with the patient, not we make the decision on behalf of the patient. And that's the bit we haven't caught up with it yet, I don't think. Your lifetime, maybe, not my one.
Yeah, just to follow up on that, I think from a sort of basic science perspective, I think it's interesting that we have. I tend to refer to them as three primary principles of, so to say something about sensitization in either the periphery or the central nervous system, and we use those as explanations to why people would hurt, also in the case of osteoarthritis, for instance. So that's the majority of research on the basic level will be understanding what osteoarthritis does to the nervous system in terms of sensitization and what markers and all that. Obviously, because that's a good target for treating the pain, so that would be pharmacological interests in targeting pain at that level. Obviously, that's not pain, it's nociception, but that's how it would be said. But when we try and understand the sort of, you could say the science of pain reduction itself, not nociception per se, but pain reduction itself, it's interesting that we don't look for reducing sensitization at all. We look at things that we also use to explain phenomena like placebo and nocebo. So we have these quite interesting ideas about a descending modulatory system that we can document, which may or may not have a long-term impact on pain. But they're definitely different from sensitization. So we don't have any descending modulatory sensitization system. We have a transient facilitatory system, as we will have a transient inhibitory system. And we use those to explain pain reduction and also why perhaps, counter-irritation techniques and cognitive behavior therapy and thought processes, etc., will have pain reductive impacts. And I guess that goes to also Dr. Haydn Gaday's question, is that all of these things in the nervous system, they might be related to sensitization. And we could explain why a person might be hurting under these circumstances. But more importantly, when we want to change pain, it actually seems that we will look at a different type of research, which I think is quite curious. That's just a reflection, a very long and babbly reflection. But it's interesting that unlike the biomechanical idea where we treat the dysfunction to cure the pain, we now have different aspects of neuroscience that we can attack and try to modulate in order to reduce pain. And Mao, there is a tremendously big glass there, Tash.
Thank you so much, Morten. So we have reached the end of our Q&A webinar. Does anyone have any last comments, any parting words they want to add to the audience?
Can I just say, I think it would be absolutely fascinating for some poor, unsuspecting patient to be put on a plinth with myself and Morten and Tash and Ben. It would take us 2 hours to reach a freaking decision, but it would be interesting to see how we got there, wouldn't it?
Well, it's an excellent plan for an upcoming webinar. We will make a note of that. Thank you so much, everyone who joined us. And thank you to our panelists for sharing their opinion and their knowledge and the research with us. This will be on the education platform, where of course we encourage you to look at other sessions and just, expand your knowledge in pain management and pain research. Thank you, everyone. Have a wonderful week.
Thank you.
Thank you too, Belinda, and thanks to everyone for checking in.
Thanks very much.